Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and we are excited to bring tonight's topic to you, transformative treatment results in plaque psoriasis and psoriatic arthritis. As moderator this evening, we have Dr. Raj Chovatiya, Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialists. As speaker this evening, we are looking forward to hearing from Dr. Raj Chovatiya, Clinical Associate Professor, Rosalind Franklin University Chicago Medical School, and founder and director of Center for Medical Dermatology and Immunology Research in Chicago, Illinois. We would like to thank our supporter this evening, UCB, for making tonight's educational event possible. A few logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just use the phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this very short survey. And also within 1 to 2 days of the webinar, you will receive a certificate of attendance. It will be emailed to you. Again, if you have any questions, we will have a Q&A portion at the end of the program. Please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Chovatiya.
Good evening, everyone. It's a pleasure to be here for yet another seminar of the IDEF. I am Dr. Raj Chovatiya from Atlanta, Georgia. And a couple of words about the IDEF. The International Dermatology Education Foundation was founded by Dr. Leon Kircik many years ago, Dr. Leon Kircik is the president of it. Is of course clinical professor of dermatology as well. The goal of the IDEF is, as a non-profit organization, is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. So when Dr. Kircik reached out to me several years ago to be part of this organization, I of course accepted with pleasure. The International Dermatology Education Foundation has had many seminars in the past, some done by really good friends of ours and people who are very well known in dermatology, and we have continued to, in fact, do so today with Dr. Raj Chovatiya, who I have a pleasure to introduce today and to be an opener for, in a way. We are at the IDEF involved in social media, and you can see the links with these different Facebook, LinkedIn, and also Instagram. I myself, I'm not really good at these. Dr. Kircik, though, really wonderful at these things. Okay. So Dr. Raj Chovatiya is here today to talk to us about transformative treatment results in plaque psoriasis and psoriatic arthritis, specifically with bimekizumab. He is a clinical associate professor, as we just said, at Rosalind Franklin University Chicago Medical School, and the founder and director of the Center for Medical Dermatology and Immunology Research in Chicago, Illinois, where it is pretty cold now. Dr. Chovatiya, I will leave you the podium.
Perfect. Thank you so much, Faraz, for the very kind introduction, and welcome everybody. Losing my voice a little bit, so bear with me while I'm perhaps not as animated as I might be with my vocal cords, but that's not enough to stop me from our topic here today, which is actually one of the more really fun stories that I think any of us in dermatology, particularly medical dermatology, has had a chance to live through and actually experience now. And of course, we're talking about Bimzelx or bimekizumab. And our topic today, and you might be saying, okay, I think I maybe heard something about this over the past year, is a little different than maybe the previous talks that you might have had on this topic. And so we're going to be talking about transformative treatment results with an emphasis on that A and that F, as this is the first and only approved IL-17 A and F inhibitor. But we're going to be really expanding our spectrum of knowledge and talking about not only approval in plaque psoriasis, but psoriatic arthritis. And I think that for the dermatology healthcare providers on the call here today, it's really important that we think about our whole patient when it comes to thinking about plaque psoriasis, which is in the forefront of our minds for many years. And psoriatic arthritis is one of those conditions that really is in hand with a skin condition. And so even though we may not be rheumatologists, we perhaps play one on TV and get to actually participate in medical care. And we're going to hear a little bit about that in today's talk. So as we go through, just remember today's talk, of course, is sponsored by UCB. Just advancing the slides here. And of course, this is a non-CME presentation. I'm being compensated for my presentation as such as well. If Michelle, you could just make sure the slide control is over to me so I can advance the slides, we can get cooking, but I don't think I have them at just the moment. Let's try again. All right, perfect. Okay, so we heard about UCB here, and we're going to go forward. So, the fun part about this talk is that I'm going to give you almost everything that you need from your clinical practice standpoint upfront. I'm not going to drag you through an entire discussion of pathophysiology before I give you what you want, but we're actually going to have a very high level pathophysiologic discussion and talk a little bit about some of these points here. And I like to think about going through university education. You have your 101, 201, 301, and 401 level classes. This is sort of the 101 data on this slide that I really want you to walk away with. And when you think about Bimzelx, I want you to really think about trying to reach for a higher bar when it comes to clinical outcomes. And that higher bar can be thought of in a lot of different ways. There's actually 3 pivotal phase 3 psoriasis trials with Bimzelx that have PASI 90 as a primary endpoint, or 90% or more improvement in somebody's psoriasis area and severity index, which is quite a high bar. And the highest bar that we have in psoriasis, there is a phase 3b psoriasis trial with PASI 100 as the primary endpoint. 100% improvement in psoriasis or complete clearance. In the case of psoriatic arthritis, we're going to talk about data for ACR 50 and ACR 70 at week 16. And for those of you that keep score in the case of psoriatic arthritis, you might be familiar with perhaps other endpoints like ACR 20 or maybe at most ACR 50. Bimzelx is indeed the first biologic to use ACR 50 as the primary endpoint. And for those of you, again, that don't think about rheumatology all the time, I'll just drop this little pearl now. Remember, when we think about the American College of Rheumatology score 50, we're referring to essentially 50% improvement in swollen and tender joints, and then 3 out of 5 particular criteria in this score, which includes a patient global assessment, a physician's global assessment, a patient pain assessment, a C-reactive protein, an ESR, and finally a health questionnaire. Now, if we want to sort of dive a little bit deeper, let's get into the numbers. So this is going to be a little bit about your 201 education, making it past freshman year into sophomore year. So if you're sort of wondering a little bit about the Bimzelx story, it can really be contextualized into rapid, complete, and maintained as far as our efficacy goes. And so when we say rapid, we're talking about, results that you can really see and patients can feel at week 4. And so as far as skin results go, we're talking about 80% or more mean PASI improvement at that time point after just a single dose of medication. In the case of joints, actually more than 40% of people achieving ACR 20, oftentimes that score that we're looking at well down the road at week 16 or beyond, typically in many other historical trials. In the case of this idea of completeness, about 6 out of 10 patients achieved 100% improvement in their PASI score, complete clearance, at week 16 as far as the skin goes. When we think about joints, more than 3/4 and half of patients achieved complete resolution in dactylitis, sort of the involvement of the fingers, and enthesitis, the insertion points of our tendons and ligaments into the bone, complete resolution. So those were no longer bothersome inflammatory symptoms. And finally, this idea of maintenance, because we know that patients want their symptoms improved immediately. They want them to get as good as possible, and they want it to stay that way. And so nearly 3/4 of patients maintained PASI 100 at year 4, and at year 2, in terms of our rheumatologic data that we have in front of you, more than 50% actually achieved that ACR 50 score at year 2 that I described for you guys. So now we're going to jump into perhaps a little more background data to really build out the story of Bimzelx. And for those of you guys that maybe are less familiar, the easiest way to think about the mechanism of action of Bimzelx, it is the first and only approved biologic that selectively targets IL-17A and IL-17F, both of which are overly expressed in plaque psoriasis and psoriatic arthritis. And so, what exactly does that mean in the case of the pathophysiology? I promised I'd give you a couple slides here, but I think this should hopefully make a lot of sense. This slide really summarizes what's been almost 2 decades or not more of immunologic work it's taken for us to understand the relatively homogeneous linear immunologic pathway we think about underlying the pathology and disease state of psoriasis. And we know that in general, upstream, we have dendritic cells. Dendritic cells are doing their thing. IL-23 is kind of important at that step. And it's quite important in particular for causing the skewing of T cells towards Th17 cells, which produce copious amounts of IL-17. Now, IL-17 is part of a larger family of cytokines that have little letters at the end of their name, IL-17, A, B, C, D, E, and F. And we'll talk about those in a moment, but they are all different versions of IL-17. I also want to highlight that there are IL-23 independent sources of IL-17, A, and F in psoriasis, ones that perhaps would not be eliminated if one was to target the IL-23 pathway alone. So this would include things like gamma delta T cells, IL-3, so these are innate types of lymphoid cells, natural killer cells, and mucosal immunity associated cells as well. So all of these are producing copious amounts of IL-17, particularly A and F. We know IL-17 has a series of homodimers and heterodimers that it forms with this A, B, C, D, and E and F. We know A can essentially bind to A and form a functional IL-17 molecule. A can bind to F and form a functional IL-17 molecule, and F itself can bind to F, form a functional IL-17 molecule. Once these bind to downstream receptors, we know that they cause increased inflammation, hyperproliferation of keratinocytes, resulting in what we think about as classic psoriatic lesions. And there's also disruption in terms of the actual osteoclast and osteoblast activity, as well as synovial cells and joints. And that's thought to underlie a lot of the features that we think about with psoriatic arthritis. Upon initiation of this immunologic cascade, there's production of further IL-17 and additional cytokines like IL-36. This is really important for certain types of neutrophilic and innate inflammation as well. So when we zoom in on IL-17, this is where the story should hopefully become a little more clear, and we talk a little bit about the value proposition that Bimzelx perhaps adds to you in your clinic. We know that IL-17F in particular can be up to 50-fold higher than IL-17A in inflamed tissues. A lot of our research historically was focused on IL-17A, but as it turns out, IL-17F has a much higher upregulation in inflammation when we think disease. And this not only includes the skin, but also the synovium and the actual joint spaces itself. If you think about IL-17A, we probably are quite familiar with blockade of IL-17A through multiple different biologic therapeutic options we've had available for several years. But if one was to block IL-17A, you might be able to block IL-17A and A without a problem, and you might be able to block IL-17A and F without a problem. But really, an IL-17F and F homodimer would pose a bit of a problem. And knowing that IL-17F is more higher upregulated in these psoriatic lesions than IL-17A, you can understand perhaps how you may not be necessarily targeting the entire spectrum of IL-17 that's important for activity here. So this is the story behind Bimzelx or bimekizumab. It selectively targets a region of IL-17A and F that is common to both cytokines, as you can see in this little antibody here. And while the clinical relevance of the mechanism of action here is unknown based on the limitations of our ability to do some of these studies in humans, we generally have this idea that with this antibody blocking A and F both, we have the efficacy and safety that we observe over the coming slides here as well. So essentially, you're providing more inhibition of inflammation than binding to IL-17A alone. So that's the end of my psoriasis spiel and exactly what's happening with joints and skin. Let's actually jump into the data here now. And we're going to maybe take it to the junior year level and go to 301 and talk about rapid, complete, and maintained, exactly those words, but really delve a little deeper into what that means for our patients. So across Bimzelx clinical trials, many of you might be familiar with treatment for patients with moderate to severe disease, and it's become quite a crowded space. And you're probably wondering, are these trials really realistically representing what I think of in terms of my patients? And believe it or not, about more than a third of these patients were biologic experienced. This includes more than half with anti-IL-17, almost 4 out of 10 with prior anti-TNF, about 16% with prior anti-IL-12/23, and another 14% with prior anti-IL-23. So the idea is that, in fact, this really looked at a broad spectrum of patients, many of which probably resembled the ones that are walking to your clinic, given their experience with other therapeutic options. So to delve in on the first part of our little three-part pillar here and talking about efficacy, let's talk about rapidity. And we can see here from the very first dose, patients experience 80% or more improvement in their PASI score across each of these clinical trials. So you can see here in the Be Ready trial, which compared with the dose of placebo, Be Vivid compared to ustekinumab, an IL-12/23 inhibitor, Be Sure compared to adalimumab, a TNF-alpha inhibitor, and Be Radiant compared to secukinumab, an IL-17A inhibitor, extraordinarily consistent results across each one of these studies in terms of mean PASI improvement, or it's essentially a way of saying percentage improvement from overall baseline. Now, if we were to sort of go a little deeper and look at PASI 90, so again, looking at the proportion of people in a binary way, yes or no, the people that got to 90% or more improvement in their PASI score, you can see here very consistently somewhere around 4 out of 10 or so patients hit that mark after just a single dose when talking about 90% or more improvement across each of these studies, and it was significant in the comparator in each of these studies as well. Now, of course, graphs can mean one thing and tables can give you something else, and me chatting away may give some of you this information, but photos really help quite a bit to spell the points that I'm trying to make. And these are some photos that are courtesy of a wonderful physician that some of you might know, Dr. Javier Alonso in Coral Gables, Florida. And you can see here, this is an example of a 37-year-old male being treated with a single dose. This is week 0 and week 3, baseline BSA of more than 10%. And this is a look at the hands. This is, believe it or not, a look at the scalp as well. And so I think that these are really helpful photos to place in some context of exactly what we just saw, knowing that individual results may vary from patient to patient. These are some photos provided by, again, some physicians that might be familiar to those of you out there in the cyberspace. On the left-hand side, we have photos from Dr. Silva from Virginia Beach, Virginia, and on the right, Dr. Galimberti from South Carolina. And you can see here, these are results looking at week 0 and week 4 in individuals that were above the age of 60 and that had a BSA above 10% as well. On the left-hand side, you can see the severity of the psoriatic plaques at baseline, on the right-hand side too, and you can take a look at the improvement during that time period. Finally, some really nice images, again, from Dr. Alonso, taking a look at images here on the left-hand side of someone with slightly darker toned skin. You can see here improvement across week 0 versus week 5. And on the right hand, we're taking a look at week 0 and a week 12. So no longer around that 1 month mark in a 52-year-old female with above 10% area. And again, you're seeing improvement on the palms and the feet here as well. So hopefully a nice swath of images and diverse skin tones across the last 3 slides that we took a look at. So what about complete clearance? Because remember, I think that I told you exactly what you probably hear, Doc, I want my lesions to be better quickly, but I also want them to get as good as possible and as clear as possible. And so just talking about complete clearance, just taking a look at PASI 90 again at week 16 as our benchmark, you can see here across these drugs, somewhere between 8 to 9 out of 10 patients hitting that mark after just a few doses of the medication itself, 4 doses to be exact. And you can see here in the comparators versus placebo, adalimumab, ustekinumab, and secukinumab, you can see clear superiority over all of these numerically and statistically as well. Now, if we were to change the bar and look at 100% clearance, so patients getting totally clear, again, it's really not even numerically close, and the statistics back that up. You can see here that around 6 out of 10 patients hit that mark of PASI 100 when looking across each of these studies, with very few patients that were on placebo for sure, and perhaps slightly higher, but still lower numbers for each of the comparator medications across each of these studies. So we talked about rapidity, we talked about completeness, but then maintenance is that last part, right? Because at the end of the day, nobody wants to be using medication that suddenly is going to drop off when they're on it in the long run. And so when taking a look at the Be Radiant study, we're going to highlight all of these features we just talked about, including the new concept in one single building graph. So from just one single dose, you can see here that nearly 4 out of 10 and maybe somewhere around 15% of patients hit PASI 90 and PASI 100 as benchmarks. And then when taking a look in this non-responder imputation, so strict data handling that you can see here statistically, by the time we get to week 16, almost 9 out of 10 patients hitting that PASI 90 mark, and nearly 2/3 of patients that are at PASI 100 with 100% clearance. Now, you can see here that at week 16, all Bimzelx patients were re-randomized to either Q4W or Q8 weeks, so essentially every 4 weeks or every 8 weeks dosing, and that will be a topic we revisit again when we talk a little bit about the on-label dosing protocol for Bimzelx. But just following these patients overall, you can see this graph build up, following these patients again in a pretty strict data handling exercise, and bottom line, you can see a high degree of maintenance overall. And so you can see here, looking at patients at 48 weeks, very similar numbers in terms of PASI 90, and perhaps even higher as far as PASI 100 goes over this time period. But that's just 1 year. Psoriasis is not necessarily a 1-year drug. You're probably wondering what's happening beyond that. Well, we're going to get to that. But just before we head over there, I want to put secukinumab up on the slide. That's the salmon pink color that just popped up, just for you to note again where some of that data with numerical superiority comes from, because this was a direct head-to-head comparison. And you can see exactly where secukinumab filters out around the squares and the triangles representing PASI 90 and PASI 100. So when we take a look at the data going up to 4 years, you can see here that perhaps your takeaway of these patients is looking around 73% maintaining PASI 100 through year 4. So you can see here the double-blinded treatment period overall, and then you can see that extension over there up to about 1 year. You can see where we're at about 1 year, and this is a modified NRI design, meaning that this is one of the stricter handlings of data you can be looking at. And so essentially what this is telling you is that an extraordinarily high percentage of patients just on Bimzelx, both Q4 week and Q8 week dosing, are actually able to keep a PASI 100 response during this longer period. And this again goes up to 4 years, and is actually a pretty recently presented data cut for those of you guys that maybe haven't seen this one before. So that's the psoriasis data, and I think some of that might be familiar to those guys who have been really keeping close watch and close score on the biologic therapy space and Bimzelx in particular. But let me introduce you to some of the psoriatic arthritis data from Bimzelx, and hopefully by the end of this, you'll understand what I mean when I'm talking about raising the bar as the first biologic to measure this ACR 50 as a benchmark at week 16 for the primary endpoint of the psoriatic arthritis trial. So we talked again about this idea of rapidity, completeness, and maintenance. So we're going to go through that same exercise here too. So after the very first dose of Bimzelx here, and all patients in the Bimzelx group got 160 milligrams every 4 weeks, you can see here in the Be Optimal trial, which included patients who had never had a biologic before, and in the Be Complete trial, which include patients that had inadequate response to TNF-alpha, clear differentiation on ACR 20 and ACR 50 between Bimzelx and placebo. The big take-home point here would be perhaps more than 40% of patients achieving that ACR 20 score after the first dose, which is oftentimes the score that we had thought about as one that we just generally kept in our mind when it came to psoriatic arthritis. However, when you actually think about what's happening over time, while a number of patients actually reached ACR 50 at week 16, and you can see here in this data set overall looking at Be Optimal for the biologic naive patients, more than 4 out of 10 patients hit ACR 50 compared to only about 10% of patients in placebo. If you track them along, you'll note that actually a higher percentage even got there overall when taking a look at what you saw by the end of 104 weeks, and when patients were flipped to Bimzelx from the placebo group. Again, they very rapidly catch up, and you have data that looks almost exactly the same from a numerical percentage wise at week 104. So more than 50% actually maintained that ACR 50 at year 2. Now, of course, we can talk about different thresholds in psoriatic arthritis. It's a tough disease to treat. It's a tough place to get penetration. And frankly, we've had to really settle on where we've been at for a number of years. So whether you're thinking about looking at ACR 20 as your historical score, or ACR 50 as sort of the first time primary endpoint score we think of, or even raising that bar one more time, which is a theme of our entire talk, taking a look at ACR 70, what you'll see is that there's rapid, complete, and actually maintained, sustained, if not increasing efficacy over time when thinking about all of these, including some of our most stringent measures, ACR 70. For those of you guys that aren't super plugged into this space, and again, I promise I'm not playing a rheumatologist here, I would not anyone to get the wrong idea, ACR 70 is not something that we generally get a chance to talk about in the dermatology world when thinking about joint data for our medications. And so it's a really fun thing to be able to discuss when talking about a drug that obviously has much of the efficacy I showed you for psoriasis. Another endpoint I think is very helpful to talk to patients about is really thinking about 100% resolution. And so that's what we're talking about on this slide for various manifestations of psoriatic arthritis at week 16. So more than 3/4 of patients had no radiographic progression when taking a look at sort of modified Sharp scoring here. More than 75%, about 76% to be exact, achieved resolution of their dactylitis in their fingers. About half achieved complete resolution of enthesitis as well, those insertion points we talk about. Up to 50% experienced no swollen joints, and nearly 50% achieved resolution of nail psoriasis, which we know has a very strong association with psoriatic arthritis itself. And when you actually take a look at minimal disease activity, I won't spend too much time talking about that as it's a criteria we don't typically have in our patient conversations. A good number of patients hit that mark too when thinking about the definitions that we have for psoriatic arthritis. So in case you're keeping score overall in terms of psoriatic arthritis, the big things I really like to talk to my patients about to take away, aside from that psoriasis data, whenever we're trying to say that, look, maybe about 4 to 10 people hit that mark of 90% or more improvement, but 80-something% improvement in the skin overall after one dose, about 2/3 of people hitting that mark within 16 weeks of 100% clearance. And when you start going to maybe about 1 year, that mark even goes a little bit higher. And now you're starting to talk about around 70% of patients, and that's really sustained over multiple years. When you think about it conversely from psoriatic arthritis, about more than 40% of people hitting that ACR 20, that baseline score that we think about in terms of achievement after that first dose. And then when we start taking a look at the data over time, more than half of people actually achieving that ACR 50 score. And from what we just talked about, whether you're looking at 20, 50, or even 70, that highest mark you had there and that long-term extension of data over time, you saw there that that was even increasing over time too. And that was around necessarily 40% as well. So multiple indications, robust data. Again, I promised there will be an explanation of that A and F in Transformative, and hopefully you got that as it's highlighted here for you guys again too. And by no means is Bimzelx a brand spanking new therapy that we have no experience with. There's more than 30,000 patients who've been treated with Bimzelx worldwide, and this is a massive phase 3/3B clinical trial program, 8 phase 3/3B clinical trials, nearly 20 years of clinical trial use across indications. So this has been studied for a very long time across phase trials. And it's now approved for active psoriatic arthritis, in addition to the moderate to severe plaque psoriasis by a number of regulatory authorities across a number of different countries. So it wouldn't be a complete talk unless I talk about something that our patients oftentimes very proactively want to discuss in the dermatology world, and that's safety. So I think I did a pretty good job of hopefully summarizing my key points for efficacy that I like to mention for both skin and joints when it comes to Bimzelx. But now let's contextualize safety into an easy to have conversation for patients too. So safety data comes from a very large population of study. Again, we're talking about more than 8,000 patient years in investigation. In terms of longer term data, 6 double-blinded trials with 3 open label extensions, more than 3,000 doses of Bimzelx overall, and a pretty robust short-term set for analysis as well. So when we think about some of our short-term data, you can see here that overall, when taking a look at Bimzelx versus placebo, some of the things that you might be interested in here include things like Candida infections, injection site reactions, ALT or AST elevations, malignancies, infections, major adverse cardiovascular events, inflammatory bowel disease, suicidal ideation and behavior, and serious hypersensitivity reactions. And these obviously draw attention in part because of what we just know in the IL-17 class. And so these are definitely events of interest. You can see here that a couple of signals are important to take away. You can see an increased amount of largely what was oral candidiasis in patients treated with Bimzelx versus placebo, highlighting what we know about IL-17, low rate of injection site reactions, not much differentiation here in terms of the liver function tests and some of the more worrisome things that we see on that list overall, no agitated SIBs or serious hypersensitivity reactions as well. If we take a look at psoriatic arthritis and we look at B optimal and B complete overall, again, for these same numbers, you'll see either similar or even lower percentages overall is the best way to contextualize that data. So nothing new that was identified in the course of those studies. Now, when we take a look at longer term safety data, this is presented in adjusted incidence rate per 100 patient years. So essentially, if I followed 100 people for 1 year, how many events might I see? Or if you like it the other way around, if I followed one person for 100 years, how many events might I see? And so you can see here that in terms of the longer term data, Oral candidiasis is highlighted over here. That drops precipitously in this group. You can see a low amount of injection site reaction, elevation in ALT, AST overall, and from some of the stuff that's perhaps bigger and scarier for patients, largely extremely low numbers ranging from 0.1, 0.2 overall. And that includes things like agitated SIB, serious hypersensitivity reactions, and agitated inflammatory bowel disease. When taking a look at psoriatic arthritis over the course of years 1 and 2, again, there's not going to be anything necessarily brand spanking new that we didn't cover overall. And you can generally see that these numbers are largely reflective, and you can see some of the same stuff here, but nothing new that's popped out. So to focus on some of the things that we talked about, I touched on candidiasis overall, something that we think about with IL-17 agents. You can see here that more than 95% of candidiasis cases were mild to moderate. About 0.7% of patients overall discontinued their medication due to candidiasis. And about 15% of Bimzelx patients experienced an oral candidiasis event in year 1, and the majority of these had only 1 event in the first year. Now, the incidence rates increased overall with prolonged exposure, suggesting that as you add time, you're not increasing events, which is always very reassuring when looking at long-term data. And what was really nice here is we oftentimes are left with these mysteries of what happened in the trials, but there was actually really nice documentation of this, and the oral candidiasis was highly treatable with antifungal therapies, typically nystatin or fluconazole in terms of the investigators, and the median duration here was somewhere around 12 days overall. So going ahead over to our next slide as we let that load up here for virtual land. It's just taking a moment for us to move. There we go. Okay. So when thinking about some of the important safety information that we have here for Bimzelx itself, remember that, oops, that was an error click on my end, that we talked about a few of these points overall. Indications, I think that I mentioned both psoriatic arthritis and psoriasis, but there's a couple of others that we didn't focus on today. So this would be active non-radiographic axial spondyloarthritis with objective signs of inflammation, active ankylosing spondylitis as well. So these are all indications that Bimzelx has under its belt. We talked a touch about the suicidal ideation and behavior data that showed the very low rates here overall. There's no causal association that's been established. And the general point that I tell folks is that overall, talk to your patients about their mental health and psoriasis. It's an important comorbidity, and we know that it's something that every patient deserves to have a discussion about, and then obviously screen for anything and follow up if needed. In the case of infections, obviously the advice on paper is to take a look at TB status at baseline, which comes up in the next point overall. We know that Bimzelx may increase the risk of infections here. Bottom line, try to make sure your patient doesn't have an active infection when you're starting them on therapy, and resolve it or pause therapy if something were developed while they're on treatment. We are familiar with tuberculosis across our psoriasis biologics, but here the goal is you want to evaluate your patients at baseline before starting. If something was to develop on therapy, you'd want to pause and get that taken care of before you went forward with therapy too. In terms of a couple of other points here, we talked a little bit about the low rate of any LFT abnormalities with increases threefold above baseline for AST and ALT. There was some of these cases, although albeit low and not that common reported. In general, you'd want to interrupt treatment if you suspected a liver injury of some sort. Sort that out before getting back to therapy. As far as inflammatory bowel disease goes, it's a point that we think about with IL-17 as a class here. There was cases reported, and the whole point here will be generally to avoid use in patients with active IBD, and then during treatment monitoring for signs and symptoms of IBD. Immunizations, something again that we've gotten familiar with biologics under our belt. The goal here would be to talk to your patients about their routine vaccinations and generally avoid live vaccines in patients treated with Bimzelx, as this never has really been studied before. The most common adverse reactions, we talked about some of these too, but this is again the common ones, not just the ones of interest. So anything above 1% in plaque psoriasis included upper respiratory tract infections, as we usually expect to see in that list, oral candidiasis, headache, injection site reactions, tinea infections, and further somewhere down the list. I won't read them all for you since you're all reading along. And then for psoriatic arthritis, the most common above 2% included upper respiratory tract infections, oral candidiasis, headache, diarrhea, and urinary tract infections. So again, consistency. And then you can see the others for the other indications overall. So let's talk a little bit about some of the practical nuts and bolts when it comes to dosing with Bimzelx, because hopefully I managed to make the case for you about perhaps the need, the mechanism of action, and then efficacy and safety summaries that might be helpful when you're having that discussion with your patient. So The dosing here is 1 dose every 4 weeks for psoriasis for 16 weeks, and then you move to 1 dose every 8 weeks. So very easy to remember. And there actually is an option for every 4-week dosing for patients that are 120 kilograms or more, which is very helpful, knowing sometimes weight-based dosing concerns we can have in our patients with psoriasis. For psoriatic arthritis, this is 1 dose every 4 weeks. That 1 dose is 160 milligrams, and very simple, just like that. There's 2 device options here. There's a pre-filled syringe and an auto injector for your patients. And then what about access and patient support? Oftentimes I know that we kind of float through this as far as an actual slide that you've probably had presented to you overall. I want to pause here as, BIMZELX has sort of, hit its 1 year that we've had it with us in clinic just about. And this has been a really vital part of my journey with BIMZELX in terms of making sure my patients have had their treatment journey as smooth as possible. And whether that be rapid access through bridge coverage, eligible commercially insured patients having affordable options for actual payment here itself, a point of contact that can help answer a lot of questions, online resources, or even financial assistance. These have all been vital for many of the different patients in the real world that I've started with BIMZELX. So it's as simple as just getting a little information on the patient at baseline and a signature, faxing that in, sending it in, and that gives you a lot of power and resources to work with field reimbursement managers, nurse ambassadors, and others when it comes to really helping your patient stay on top of their therapy or figuring out any roadblocks for approval. And of course, your UCB representative would be happy to provide you with more information about this program as well too. So back to that data that I started out with. Again, hopefully I took you through your whole college experience in terms of all 4 years of data. But remember, this was sort of what I wanted you to really take away as the bottom line data for discussion. Whether you're talking about rapid across skin and joints, complete or maintained efficacy, I think largely you can see that across the numbers that are presented here. So whether you're looking at mean PASI improvement or ACR 20 in the early phase, whether you're looking at, excuse me, whether you're looking at complete clearance in terms of PASI 100, whether you're looking at individuals having complete clearance of their dactylitis and enthesitis, or whether you're looking at patients that are trying to maintain that complete clearance or an ACR 50 score at year 2, BIMZELX really hits the mark on each one of these. And I think that these are all really helpful points our patients like to know about when we're really trying to talk about why a therapy might be right for them. So BIMZELX, again, to remind you, is the first and only approved biologic that targets IL-17A and F, particularly in plaque psoriasis and psoriatic arthritis. And I do want to highlight an opportunity for those of you out there that you actually can see transformative treatment results that your peers have seen in the clinics. The BIMZELX Transformation is a web-based portal featuring real patients with real-world results. You can actually share your own success stories with your peers. That's how we got some of these wonderful photographs you've seen from some of your peers out there. Great clinicians, great photos actually that they took overall. And there's a QR code here to give you a little more information to submit your case to the BIMZELX Transformation portal. And this will be a part of the story that will be evolving in real time. So you may actually see your photos presented if you have me back to talk through this at some point in the future too. That is my last slide. And so I just want to say thank you to you guys. And Faraz is right back on. Happy to take any questions that come up.
Raj, thank you very much for an excellent presentation. One of the questions that comes up is how do you, what is your concern about oral candidiasis and how do you treat it?
Yeah, great one. So I can speak from my personal clinical experience in the real world with BIMZELX use. First of all, it's not really been much of a concern in my patients that I've treated, in that I really haven't had to do much about it because it hasn't really come up. But for the patients where this potentially may be an actual adverse event, it's really nice to have data from clinical trials that actually is able to tell you what people did in the real world. And quite simply, for the cases where it was to occur, but very easy first-line therapies that we're very used to using in dermatology, like nystatin in terms of contact treatment, or oral fluconazole, literally for 2 doses that are maybe separated by the week apart. That's really about it. And so I think that adverse events are never something you want to experience with a medication, but it's important to know about them. If that was, treatment limiting is not the word I think about it, but more of just something to deal with that is pretty swift and pretty easy overall.
Wonderful. Well, Raj, thank you very much for a great presentation. It has been a pleasure to have you all in our webinar tonight. And please, if you have any other questions, submit them now. Otherwise, we will go ahead and close the meeting. Thank you all for your attendance.
Thanks, everyone.
We're good to go. Thank you. Thanks, Raj. Have a good day.